morning and welcome to the July webinar hosted by the Becky Career Development Subcommittee. My name is Brittany Bell and I'm the chairperson of the Career Development Subcommittee. Today we are joined by Stacy Conkle, a PhD candidate in epidemiology at the University of Louisville, who will be presenting on volatile air pollutants. Before we get started, I wanted to discuss a couple of housekeeping issues. All participants have been placed on mute for this webinar. If you have a question for the presenter or the webinar administrators, please use the chat box. There will be time for a question and answer session at the end of the webinar. This webinar is also being recorded and will be made available on YouTube. You can find the playlist of Becky webinar recordings on the Kentucky Department for Public Health YouTube channel. If you are interested in presenting for future webinars, please contact me at brittany.n@ky.gov or send a message in the chat box. With that, I'll turn the webinar over to Stacy.
Okay. Hopefully you can hear me. Okay. So I'm Stacy Conkle. I'm a PhD candidate in the epidemiology department at the School of Public Health and Information Sciences at the University of Louisville. I'm currently doing research at the Superfund Center, which is part of the newly formed Envirome Institute in the Department of Medicine at U of L. The research at the Institute is focused on investigating the human-environment interrelationship, and our long-term mission at the Institute is to study the human envirome with the same precision and rigor that was applied to decoding the human genome. My research within the Institute is focused on assessing the associations between volatile organic compounds and cardiovascular and metabolic disease. Today I'm going to discuss the definition and known health effects of volatile organic compounds. I will define and discuss the epidemiology and population impacts of cardiometabolic syndrome. And then I will talk about my research in tobacco smoke and cardiometabolic syndrome, the associations between volatile organic compounds and cardiometabolic syndrome, trends in ambient volatile organic compounds, and an innovative study at the Institute known as the Green Heart Study. Current evidence for the effects of volatile organic compounds on cardiovascular and metabolic outcomes is not robust. However, the available epidemiologic and experimental data suggests that exposure to volatile organic compounds contributes to the cause of cardiovascular disease, hypertension, and metabolic dysfunction, but further investigation is needed. Therefore, the objective of my investigations is to evaluate the associations between volatile organic compounds and cardiometabolic syndrome. My central hypothesis is that volatile organic compounds contribute to cardiometabolic syndrome through reactive metabolites that induce physiologic responses provoking cardiometabolic changes. First, volatile air pollutants, or more specifically, volatile organic compounds, or VOCs for short, are generally considered any organic compound with an initial boiling point less than 250 degrees Celsius. And the EPA defines VOCs as any carbon compound which significantly contributes to atmospheric photochemical reactions. VOCs are both naturally occurring as well as man-made chemicals and can be released directly into the environment or by incomplete combustion of organic matter. Globally, fossil fuels account for nearly half of the anthropogenic VOC emissions. Biomass burning makes a significant contribution at 26%. Burning of biofuels makes up another 16%. Various industrial processes account for approximately 14%, and waste management adds an additional 2%. VOCs exist in the vapor phase, particle phase, or both, depending on the situational equilibrium of the particle surface. Generally, VOCs are not visible by the naked eye, but are often recognized by their odors. So I have a little video here. Let's see if we can get this to work. All right. So this thermal infrared video shows the vapors that I'm sure we're all familiar with as we fill up our gas tanks. These black, I guess, smoke-looking vapors are, like I said, the vapors, and these are VOCs. VOCs have traditionally been studied in a single exposure context, and this table summarizes the existing information on the health effects of each VOC of interest in my investigations, as reported by ATSDR, which is the Agency for Toxic Substances and Disease Registry. On this chart, the H's indicate evidence from a human study, and the A's indicate evidence from an animal study. As you can see, all the VOCs of interest in my investigation have been associated individually with numerous adverse health effects, including cardiovascular and metabolic effects. Furthermore, ATSDR has ranked several of the VOCs of interest among the chemicals of top priority to public health. This list is comprised of chemicals determined to pose the most significant potential threat to human health and is a prioritization of substances based on a combination of their frequency, toxicity, and potential for human exposure. In addition to the single pollutant exposure assessments, multi-pollutant exposure analyses, which assess pollution exposure in a more natural exposure spectrum, have examined associations between VOCs and non-accidental cardiovascular and cancer mortality, as well as fasting glucose, insulin, HOMA-IR, adiponectin, resistin, leptin, and HbA1c. These multi-pollutant exposure analyses begin to address the independent, synergistic, and antagonistic effects of air pollution and VOC mixtures. In a paper published earlier this year in The Lancet, it was estimated that 2.4 million deaths were attributable to air pollution globally in 2015. The paper projected that this number would rise to 6.6 million attributable to air pollution by 2050. This paper also estimated that 71% of the total burden attributable to air pollution is non-communicable diseases. In 2015, air pollution was responsible for 21% of cardiovascular disease mortality, 26% of ischemic heart disease mortality, and 23% of stroke mortality. Very little is understood about the effects of volatile organic compounds on cardiometabolic syndrome. However, various links between aspects of cardiometabolic syndrome and exposures containing or associated with VOCs have been assessed. One of the predominant forms of assessing pollution exposure associations in health effect studies has been by measuring particulate matter, or PM. And VOCs contribute to the composition as well as the mass of PM, so it's reasonable to assert that PM could possibly be a proxy for actual VOC exposures. Long-term PM 2.5 exposures have been associated with incidence rate ratios of hypertension of 1.48 for every 10 milligrams per cubic meter increase in PM 2.5, and a corresponding incidence rate ratio for diabetes of 1.63. Other studies using PM as a measure of exposure have found associations with non-accidental mortality, cancer mortality, cardiovascular disease mortality, respiratory disease mortality, and hypertension. Traffic-associated exposures have also been linked to non-specific fatal stroke, type 2 diabetes, excess cardiovascular disease mortality, and incidence, prevalence, and onset of myocardial infarction. Industrial emissions and occupational exposures of VOCs have also been linked to adverse health effects. For example, an evaluation of the health effects of 72,000 individuals living within 1/2 mile of 258 Superfund sites found excess rates of stroke and type 2 diabetes. Residential proximity to trichloroethylene emitting sites has also been associated with infant coronary heart disease risk. And other industrial emissions and occupational VOC exposures have been associated with excess cardiovascular disease, stroke, cardiac injury, atherosclerosis, hypertension, dyslipidemia, and high triglycerides, as well as electrocardiogram abnormalities. Cardiometabolic syndrome is a compilation of a number of dysfunctional cardiovascular and metabolic conditions. There is currently no universally accepted definition of cardiometabolic syndrome, and to date, at least 5 organizations have posed clinical criteria for diagnosing cardiometabolic syndrome. The most common characteristics for defining CMS are insulin-resistant glucose metabolism, which is generally measured as impaired fasting glucose, impaired glucose tolerance, or the presence of type 2 diabetes. Abdominal obesity, which is often measured as BMI or waist circumference. Dyslipidemia, which is measured as high triglycerides or low serum HDL cholesterol. And hypertension, which is defined as a blood pressure greater than or equal to 140/90. The criteria proposed by the World Health Organization are the most widely accepted criteria and include the presence of microalbuminuria. Diabetes, hypertension, hyperlipidemia, and obesity often cluster together in the same individual. This clustering of risk factors is cardiometabolic syndrome and substantially increases one's risk of cardiovascular disease mortality. In fact, it has been shown that as the number of cardiometabolic syndrome risk factors increases, so too does cardiovascular disease mortality. As you can see here, it has been shown that having 1 or 2 risk factors nearly doubles your risk of cardiovascular disease mortality. Having cardiometabolic syndrome nearly triples your risk of cardiovascular disease mortality, and having cardiometabolic syndrome plus type 2 diabetes is nearly equivalent to having diagnosed cardiovascular disease. Additionally, individuals who have established cardiovascular disease plus type 2 diabetes have an almost 8-fold increase in risk of mortality as compared to individuals with no established risk factors. In the United States, 29 million people have diabetes, 70% are overweight, 1/4 of the population is living with cardiovascular disease, and over 30% of the population is hypertensive. Collectively, this leaves 1/3 of the American population meeting the criteria for cardiometabolic syndrome. The economic impact of cardiometabolic syndrome is enormous. In fact, it has been established that the national medical expenditure attributable to cardiometabolic syndrome is over $80 billion annually. Additionally, because cardiometabolic syndrome significantly increases the likelihood of developing cardiovascular disease, the annual economic cost attributable to cardiovascular disease, which is over $395 billion, is also notable. The mechanism responsible for the development of cardiometabolic syndrome is not known. However, it is likely that multi-organ insulin resistance is involved. The 3 most important risk factors for developing cardiometabolic syndrome are smoking, high cholesterol, and high blood pressure. Other established risk factors are hyperglycemia, chronic inflammation, diabetes, obesity, diet, alcohol consumption, low socioeconomic status, and physical inactivity. There are many risk factors that play a role in the propensity for an individual to develop cardiometabolic syndrome. Of the modifiable risk factors, my research focuses on developing the associations between one of the major constituents of air pollution and cardiometabolic syndrome. The epidemiologic link between cardiometabolic syndrome and VOCs is important to establish, not only as hypothesis-generating studies to inform and guide more in-depth toxicologic investigations, but also as supporting evidence for environmental public health policy activities. Therefore, the objective of this investigation is to evaluate the associations between volatile organic compound exposures and cardiometabolic syndrome. So the first question I asked when I got here was, do smokers have more exposure to volatile organic compounds? And if so, do they have more cardiovascular and metabolic risk factors? But this is really a two-part question. So to answer the first part of the question, which is, do smokers have more exposure to volatile organic compounds? I addressed the hypothesis that levels of urinary VOC metabolites will be higher in smokers as compared to non-smokers. The rationale for looking at tobacco smoke as a source for volatile organic compounds is that there are approximately 600 ingredients in cigarettes, and when combusted, generate more than 7,000 chemicals. At least 69 of these chemicals are known human carcinogens, and many more are considered poisonous. Several of the chemical constituents present in conventional cigarette smoke are VOCs. Therefore, cigarettes may be considered a chronic high-dose exposure of volatile organic compounds. To address this hypothesis, I assessed a group of individuals from the Jackson Heart Study cohort, which is a well-established longitudinal cohort of approximately 5,300 African Americans living in Jackson, Mississippi. The Jackson Heart Study focuses on studying relationships with clinical and subclinical cardiovascular disease. To test my hypothesis that VOC metabolites will be higher in smokers as compared to non-smokers, I assessed a group of 455 smokers and 779 smokers who were age and sex matched based on smoking status. For my study, smoking status was defined using a urinary cotinine cut point of 45.19 nanograms per milligram. For this analysis, I was interested in 18 parent VOCs. When an individual is exposed to a parent VOC by inhalation, ingestion, or dermal exposure, the body metabolizes the compound into metabolites, which are then excreted in the urine. These urinary metabolites of VOCs can be used to assess individual level biomarkers of exposure to VOCs. The urinary metabolites for this analysis were measured by ultra-performance liquid chromatography coupled with electrospray tandem mass spectroscopy. For this analysis, there are 28 urinary VOC metabolites from 18 parent compounds. This is the table 1, or the demographics table, for the Jackson Heart Study. As you can see, smokers have lower BMI and take fewer blood pressure medications, and more smokers consume alcohol, identify as having poor health, and identify as having lower income. So the next thing I did was I began to look at the VOCs. This table reports the level of detection and the percent of participants with values reported above the level of detection for each urinary VOC metabolite. The level of detection, or LOD, is the lowest quantifiable level that is able to be detected by the lab's protocol for each metabolite. As you can see from this table, 6 of the metabolites have less than 15% above LOD, and these metabolites will be removed from any further analyses. To assess the correlations between VOCs, next I assessed the correlations between VOCs. On these graphs, the brighter the green, the stronger the correlation, and the darker the green into the red is the weaker the correlation. You can see from these correlation matrices of the log-transformed creatinine normalized VOC metabolites that smokers have very strongly correlated VOCs. This is supporting evidence that these VOCs really are coming from the tobacco smoke. This table reports the means and standard deviations for the full cohort, as well as for smokers and non-smokers. Additionally, t-tests were conducted to assess which VOCs were statistically significantly different between smokers and non-smokers. you can see that smokers have statistically significantly higher levels of 16 of 18 metabolites as compared to never smokers. The two metabolites in red there that were not significantly different between smokers and non-smokers are BMA, a metabolite of toluene, and BPMA, a metabolite of 1-bromopropane. When linear regression models were built to assess if smoking status, so smoke yes, no, predicts individual level urinary VOC metabolites, 11 of the 18 urinary VOC metabolites were able to be significantly predicted by smoking status. Additionally, this graph shows smokers' VOC concentrations normalized to non-smokers' VOC concentrations. The standard deviation is reported on the x-axis, and each individual metabolite is reported on the y-axis. This graph essentially shows the excess VOC metabolite exposures for smokers, or in other words, what smokers get in excess of non-smokers. So now we are back to the question, do smokers have more exposure to VOCs? And if so, do they have more cardiovascular and metabolic risk factors? I have essentially effectively answered the first part of the question, and shown that smokers do have more exposure to volatile organic compounds. Now we have to address the second part of the question. Do smokers have more cardiovascular and metabolic risk factors? And if so, can we link them to VOCs? To address if smoking-related VOCs are associated with cardiometabolic risk factors, I used the NHANES survey. NHANES is the National Health and Nutrition Examination Survey and is designed to assess the health and nutritional status of adults and children in the U.S. NHANES is a major program of the National Center for Health Statistics, which is part of the CDC and is responsible for producing vital and health statistics for the nation. NHANES began in 1960 and became a continuous annual survey in 1999 with data released to the public in 2-year intervals. The survey examines a nationally representative sample of approximately 5,000 persons throughout 15 counties across the U.S. each year. Interviews, physical examinations, and laboratory tests are conducted on each person. The exposure of interest, again, in this investigation are those same 28 urinary VOC metabolites from 18 parent compounds, which I assessed earlier in the Jackson Heart study. The outcomes of interest in this investigation are HDL, triglycerides, and dyslipidemia. So here's the table 1, or the demographics table, for the NHANES 2011-2012 cohort, which is approximately 800 individuals. The demographics of this subsample are presented here, and as you can see, approximately 12% of the population has diabetes, dyslipidemia, or hypertension. 58% are non-smokers. Most have at least a high school education and own a house, and the average age was 46. I examined the associations between urinary metabolites of VOCs and serum lipid levels using survey-weighted regression models adjusted for significant covariates, age, sex, race, and BMI. This radar plot shows the percent change in HDL per interquartile range of each VOC. So the way you read this chart, so again, this is only in smokers, and the way that you read this chart is that the white circle here is 0% change. And because this analysis is looking at HDL, and HDL is your good cholesterol, we would be particularly interested in associations with decreased HDL. So we're looking at the associations, or the red that is inside the white circle. As you can see, amongst smokers, there were 13 VOCs that were negatively associated with HDL that ranged from -0.3% to -3.6% per VOC interquartile range. So that's all of these VOCs. The VOCs with the asterisks and the underline are the significant associations. This radar plot shows the percent change in triglycerides per interquartile range of each VOC. So again, this is only in smokers, and the white circle here is again 0% change. But because this analysis is looking at triglycerides, and triglycerides are bad, we would be interested in VOCs that have positive associations. So that would be these VOCs here with, or we're looking at the red outside the white line here in the VOCs that are significantly positively associated. So as you can see, amongst smokers, there are 13 VOCs that are positively associated with triglyceride levels that range from 0.5 to 8.3% change per VOC interquartile range. This radar plot shows the odds ratio of dyslipidemia per interquartile range of each VOC in non-smokers. So this analysis is only done in non-smokers, and the way you read this chart is that the white circle here is 1 because we're looking at the odds. And so we found that in non-smokers, increased odds of dyslipidemia was associated with 6 VOC metabolites. So collectively, these findings suggest that VOCs, particularly 1,3-butadiene and trichloroethylene in concentrations found in conventional tobacco smoke, and 1,3-butadiene and xylene at concentrations found at general environmental levels, are associated with cardiovascular disease risk by inducing dyslipidemia. So in summary, our question was, do smokers have more exposure to volatile organic compounds? And if so, do they have more cardiovascular and metabolic risk factors? We have shown that smokers do, in fact, have more exposure to volatile organic compounds, and that smoking-related VOCs are, in fact, associated with cardiovascular and metabolic risk factors. While I was addressing this hypothesis, I became very intrigued by the associations with HDL and triglycerides in non-smokers. These associations imply that even very low dose chronic exposures of VOCs may be linked to cardiometabolic risk. So now I'm interested in looking into associations between ambient VOCs and cardiometabolic syndrome. To assess the link between environmental air pollutants and cardiometabolic risk, I first wanted to examine if trends in national ambient VOC levels were reflected in VOC biomarkers of exposure and associations with cardiometabolic syndrome in a nationally representative survey. So here, instead of looking at smoking, I'm interested in only non-smokers as, a proxy or a measure for air pollution exposure. To do this, I used data on 16 of the urinary VOC metabolites from approximately 2,435 participants in the 2005, 2006, 2011, 2012, and 2013-2014 NHANES cycles. These are all the years of NHANES that have urinary VOC metabolite data and also allow me to assess trends in VOCs over a 10-year period. This analysis excluded individuals reporting any exposure to tobacco smoke. To examine associations between urinary VOC metabolites and cardiometabolic syndrome, I built individual level survey-weighted logistic regression models adjusting for significant covariates, age, sex, race, and BMI. Next, I assessed national ambient VOC trends using air toxics data from the National Monitoring Program from 2005 to 2013. This chart shows the year on the x-axis and the parts per billion volume on the y-axis for each ambient VOC. As you can see, all ambient VOC levels decreased from 2005 to 2013, some more substantially than others, but all decreased. This graph shows the urinary VOC metabolites on the x-axis and the mean % change in urinary metabolites in NHANES participants from 2005 to 2014 on the y-axis. All but 4 metabolites increased from 2005 to 2014. So all ambient VOC concentrations decreased from 2005 to 2013. However, the metabolites of the VOCs, metabolites from all VOCs except propylene oxide, styrene, and 1-xylene metabolite increased, with acrylonitrile and 1,3-butadiene having the largest increases. Additionally, increased odds of cardiometabolic syndrome were significantly associated with increased levels of 1,3-butadiene, ethylbenzene, and 2-acrylon metabolites. Decreasing national ambient VOCs combined with increasing urinary metabolites of VOCs in participants from NHANES 2005 to 2014 suggest ambient VOCs are not the primary source of VOC exposure in the U.S. population. Our study suggests that decreasing ambient VOCs alone is not sufficient to protect against adverse cardiometabolic health effects associated with exposures to cardiometabolic syndrome. So moving forward, I have received data from the EPA on VOC productive volume in the US from 2005 to 2014, which I'm using to assess if increases in personal level VOC exposures could be correlated with increases in manufacturing processes and commercial product use. Additionally, I'm working on combining all 3 cycles of NHANES with urinary metabolite of VOC data to assess associations with individual level urinary metabolites of VOCs and cardiometabolic syndrome. To the best of my knowledge, this analysis will be the largest, most comprehensive assessment of urinary metabolites in VOCs and will address effects of VOCs on health in both an individual manner as well as from a global viewpoint using multi-pollutant combinatory modeling. But that's not all. Here at the Envirome Institute, we are committed to not only producing state-of-the-art research, but we are also committed to putting our research into action. We are currently enrolling participants in a first-of-its-kind community-based clinical trial type investigation exploring the relationships between health and nature. Instead of testing a pharmaceutical drug like in a conventional clinical trial, our participants will be receiving trees. This study, known as the Green Heart Project, will provide for the first time an assessment of the impact of vegetation on the health of individuals and their surroundings. The project will move the field forward by facilitating the development and evaluation of a new approach to prevent cardiovascular disease by mitigating air pollution through increasing vegetation. Over the next 5 years, we will enroll approximately 700 participants in 6 neighborhoods in South Louisville. We will measure the air pollution. We will plant approximately 8,000 trees in these neighborhoods and collect data on the built environment, cardiovascular health, hospital emissions, increase in green space, neighborhood demographics, pollution levels, socioeconomic position, and volatile organic compound exposures. So I wanted to thank Brittany for inviting me to give this webinar and for everyone who called in to participate. And I guess now I'll try and answer any questions that anybody has.
Thanks, Stacy, for presenting for us today. And like she said, at this time, we'll open the floor for any questions from the audience. Feel free to type it into the question box or the chat box. If you can't think of anything right now, feel free to email me or Megan Hurst later, and we'll be happy to forward your questions to Stacy so she can address them. So if you have any questions, please type them in the box and we'd be happy to address them. I haven't seen any questions come in, so we'll go ahead and wrap up. And if anyone thinks of anything after we sign off, like I said, feel free to send me an email and I can get this sent over to Stacy. So that concludes our July webinar. Thanks everyone for calling in and learning a little bit about volatile air pollutants. Recording of this webinar will be available shortly on YouTube. All you have to do is search for the Kentucky Department of Public Health, and you should see a playlist with all of our previous webinars. If you're interested in presenting during a future webinar, please send me an email or send a chat message via the webinar. We'd be happy to have you present for us. Thanks again for attending, and be sure to tune in on our August webinar, which is Tuesday, August 14th at 10:30 a.m. Thanks very much and have a great day.